Welcome, everyone. All right, well, Pete, maybe if you want to go ahead and get started. I know we have, I think, an introduction slide just to let everybody know who you are, and we'll kind of get going there.
Absolutely. Well, welcome, everybody. My name is Pete Yunyongying. I am a physician and clinical professor of medicine at the Carle-Illinois College of Medicine. I'm ABIM board certified in internal medicine, and I've done my training at University of Texas Southwestern Medical Center and University of Maryland College of Medicine, amongst several other institutions. I'd like to welcome you all. Thank you for taking the time to join us today. Some quick housekeeping items. Feel free to ask any questions in the chat. I have some colleagues who can help us look at the chat and keep me informed. We'll try to have some time for questions and try to pause periodically to address some of those. Today is a special webinar. It's a Medmastery webinar in partnership with HumanDx, and we'll get to that in a second. But our focus today is on decision-making. Decision-making used to be fairly straightforward. We could talk to the patient, but our physical exam was often limited by what we could see, how we could feel with our hands. We didn't have blood work, we didn't have MRIs, we didn't have CT scans, and with limited data points and even more limited therapeutic options for our decisions, they were very limited in scope. Modern medicine, on the other hand, is a very different world. We face a major problem, and that problem is data. How do we integrate all of the history, all of the physical exam, all of the laboratory, and all of the radiologic data to make decisions? How do we decide what the diagnosis is, what the treatment options are, and what further testing we might need? In this webinar, we will introduce you to one way to help improve your clinical decision-making and reasoning. For more ways to refine your skills, check out courses on Medmastery and use the app HumanDx to test your diagnostic skills. Clinical decision-making can be thought of in two main modes: pattern recognition and logic. Pattern recognition is faster, but can be prone to errors. For instance, the initial pattern can be misrecognized, leading to errors. Logic, on the other hand, or reasoning, is more reliable. It's consistency in results with fewer errors, but it can take time and be costly. In the clinical setting, it often requires more testing and follow-up visits. I apologize for some of the technical hiccups. We'll try to keep it to a minimum. First, let's talk about pattern recognition in more detail. Upon your initial observation of anything, it's impossible to see every detail. Instead, we recognize and interpret certain pieces of information while disregarding others. We rely on instincts, intuition, and past experiences to guide us. It helps us determine which information to make note of and which to ignore. For example, as you watch these dots populate, at what point did you recognize a bird? Perhaps you have heard the expression, when you hear hoof prints, think of horses, not zebras. While pattern recognition can offer answers rapidly, it's particularly prone to mistakes. You must consider the influence of cognitive biases like affective bias or implicit bias. For instance, if the last 3 patients you saw with shortness of breath were diagnosed with pulmonary embolism, you are more likely to suspect the next patient with shortness of breath as having pulmonary embolism, simply because of recent history. Similarly, if you had only seen COVID-19 patients with loss of smell and taste, in this case, how likely were you to consider COVID-19 with no loss of sensor of smell or taste, such as that we're seeing with the Omicron variants that lack these hallmark characteristics of the early COVID-19 presentations? As mentioned previously, another problem with pattern recognition is that some details appear more important than others. If you happen to choose the correct set of details, then you can make out the picture faster. But if you focus on the wrong set of details, you can be led astray and accidentally arrive at the wrong conclusion. In these two famous examples of the same image can be interpreted in two very different ways. Which is right and which is wrong? On the left, do you see an old woman or a young woman? On the right, do you see a duck or a rabbit? The second method of decision-making is based on logic and reason. In truth, this method can be employed in a variety of ways. There are many different styles of logic that can be used. Some examples are inductive logic or deductive logic, Bayesian logic, and process of elimination. The problem with this mode of clinical decision-making is that it can cause us to search for patterns within a set of data where a pattern may not exist. In fact, we're inclined to add details in order to fill in the missing pieces of the puzzle. This is called imputation. Imputation allows us to make sense of the data we've collected. Alternatively, we could use the approach of asking certain questions to rule in or rule out different possibilities. If we ask the correct sequence of questions, we can narrow down, sorry about that. If we ask the correct sequence of questions, we can narrow down the possibilities enough to take an educated guess that is more likely to be correct than taking a random guess. A good example of this would be the game 20 Questions. This game originated in the 19th century in the United States, and it found a resurgence in popularity in the 1940s with radio and TV shows in various parts of Europe. Participants would have to guess what one person was thinking after asking only 20 questions or less. Each question was limited to yes or no answers. By choosing questions strategically, the questioner could eliminate possibilities sufficiently enough to take a good guess. The predominant mode of reasoning used in this game is deductive logic. Assuming that we pick the correct questions and the correct sequence of questions, a yes and no answer eliminates certain possibilities, leaving by process of elimination only a few choices for the correct guess. Unfortunately, logic and reasoning is not always perfect for arriving at the correct diagnosis. Like pattern recognition, logic and reasoning is also limited by its own set of potential mistakes. Logic fallacies that are based on the wrong assumptions can lead to erroneous conclusions. Cognitive biases and implicit bias can lead to flawed logical assumptions. In reality, no single method of decision-making is perfect. In fact, most clinical decision-making is a hybrid of the two methods we've just now described. We use some aspects of pattern recognition and some aspects of logic and reasoning to try and balance the need for speed and cost with reliability and consistency. An example from World War II illustrates how using a hybrid approach can greatly improve decision-making. Military experts analyzed the bullet holes of planes that returned to base after flying combat missions. They then used the bullet hole analysis to reinforce areas where there were the most bullet holes. This initial step is an example of pure pattern recognition. See bullet holes, fix bullet holes. However, this did not reduce losses to airplanes in combat. So they revisited the analysis using the same visual pattern and considering different possibilities. The reinterpretation of the same data set revealed a better solution. What they learned was that those areas where there were no bullet holes represented portions of the most vital components to a plane's survival. There were no bullet holes in those areas because those planes that were struck in those locations failed to survive. It was a logical fallacy with pure pattern recognition in the first analysis. For those of you interested, this is an example of survivor bias or survivorship bias. The solution then was to reinforce the areas without bullet holes. Pattern recognition alone can be subject to misinterpretation, and survivorship bias teaches us that. This emphasizes the value of implementing additional steps to check for bias and inaccurate assumptions if we're relying on pattern recognition alone. Let's look at how these two methods can work together in a typical case. Consider that someone comes into your office complaining of a sore throat. There are so many causes for sore throat that it can be difficult to know where to start. Is it a foreign body that's causing esophagitis? Is it thrush? Is it esophageal cancer? Is it infectious pharyngitis? Where do we even begin? One approach could be to use deductive logic. Like the game 20 questions, we can eliminate certain possibilities and hone in on which possibilities are the most likely. You can start by asking a few questions, like whether there are sick contacts or whether this is acute or chronic in nature. At a certain point, you can start to get enough detail to switch to pattern recognition. For instance, you might realize it's some sort of infectious pharyngitis. Unfortunately, there's two broad categories for infectious pharyngitis: bacterial and viral. So now you have to ask yourself, could this be strep pharyngitis, where we would need to treat with antibiotics? Or is this viral pharyngitis, where using antibiotics might pose potential harm, like an increased risk of C. difficile colitis or antibiotic resistance? Getting the answer wrong has certain serious consequences. Relying on pattern recognition alone may not be the wisest choice. Here again, we can use some logical reasoning to focus the picture more. Dr. Robert Centaur originally identified 4 key findings that make strep pharyngitis more likely. Further refining his original work, the McIsaac criteria, otherwise known as the modified Centaur criteria, can be used to focus our clinical picture more. By using sets of criteria, that helps us narrow down our possibilities and then guiding our decision-making, we're able to switch back and forth between pattern recognition and logic and reasoning to arrive at a much more consistent answer. In this case, we know that using the modified Centaur criteria allows us to take an educated guess about the need for further testing versus the value of empiric antibiotics. It doesn't tell us definitively what the diagnosis is. However, it gives us enough information to act quickly. Research has shown that confirming the cases more definitively with more testing is not likely to improve our health outcomes significantly. In fact, doing so could even lead to delays in treatment or increased costs. In other words, in some cases, a blurry but still recognizable picture is still good enough. However, in other cases, you may need a very clear and detailed picture before choosing to act. The choice of acting on a blurry versus a clear picture depends on many factors. One factor is an assessment of the need for acting quickly. Another factor is the need to balance the consequences to the patient if you're wrong. A general 5-question rule of thumb to guide you can help make some of these decisions. 1, how quickly do you need to act to prevent major morbidity or mortality? 2, what is the most likely diagnosis? 3, what else could it be if you are wrong? 4, what are the consequences to the patient if you're wrong? And 5, how might you mitigate the consequences if you're wrong? Would confirming the diagnosis further reduce the harm or introduce new harm if you happen to be wrong? So it's clear that hybrid decision-making allows us to balance the benefits of both modes. A hybrid will give us the benefit of the speed for pattern recognition and reliability of logic and reasoning. The key to decision-making is to understand that we are looking for perfect, error-free decision-making, but we have to balance everything. We're not looking to be perfect all the time. We're looking to be reliable enough that our errors are minimal and inconsequential. We must aim to limit the harm of our mistakes and maximize the likelihood that we're taking the most beneficial course of action. That is the challenge of clinical decision-making. Let's consider how to apply these elements of hybrid decision-making to a case found on HumanDx. This short webinar is not meant to cover everything. This is a very in-depth scenario. For more information on clinical reasoning and decision-making, please explore more courses at medmastery.com and HumanDx. But I'm going to take a quick break now, see if there's any questions or comments, and then with the time remaining, we can explore one example case from HumanDx. What questions might you have or comments?
Are there any questions? Feel free to drop them in the chat box.
There are a couple of you that mentioned that they didn't receive the case. That's okay. We will go over the case briefly. And this next section of the webinar is really just meant to be interactive. So, ask questions, use the chat. We'll let you unmute from time to time so that we can hear from you as well.
We'll also send out there'll be a recording of the webinar, which we will send out on Friday, I believe. We have an email that goes out. It's our Intelligent Thursday tomorrow, so it won't go out tomorrow, but it'll go out Friday, the recording of the webinar. And we'll also send the link to the case out on Friday so that you can do the case that we are mentioning. There's also other cases that are on HumanDx that you can choose other cases that you might want to work through. So we'll send a link out to that as well in case you didn't get a chance to work through the case. And there are also cases in the Medmastery platform as well. There's both lecture format and Medmastery webinar-ish type formats, but then there's also some case series that can help you refine your skills. We have workshops, so I see somebody's raised their hand.
Yeah, you had a question?
Do they have the ability to unmute themselves, or can I? Nora, can you unmute them?
They are unmuted. Leah, can you unmute yourself? You have to click on the mute button because you're muted. Meanwhile, we have a question from Carla. Please explain Bayesian theory.
Yes, Bayesian theory. Bayesian theory is an interesting world. It's a purely mathematical and probabilistic way of thinking. So not to make a mess of mathematics and statistics, the simplest way to think about Bayesian theory is when given two choices, both of those choices are not always equal in probability. And each of those choices can then lead to future choices that may or may not be more or less likely based on the first choice. So the most common example that we see is a statistic called likelihood ratio. And it uses the idea of pre-test and post-test probabilities. The most well-known example in clinical research are the PIOPED studies. That's PIOPED, I believe. And if you want to Google those original articles, you can do so. The PIOPED studies set up a scenario where patients presented with shortness of breath, and the clinician was asked how likely they thought the patient had pulmonary embolism prior to doing any testing, just based on history and physical exam. They then were asked to choose a diagnostic test. PIOPED 1 used VQ studies or perfusion ventilation studies. PIOPED 2, I believe, used CT pulmonary angiography. And then they've been further refined with other variants. What they found was that if your pretest probability based on clinical history and physical exam was very, very high, or if your clinical intuition said that a PE was very unlikely, that the VQ scans results correlated very, very well with that clinical intuition. However, if you had an intermediate probability, pretest probability, as they say, for PE, meaning there were some aspects of the case that kind of sounded like a PE, but then there were other aspects of the case that made PE much, much less likely. Maybe it was a history of asthma for the patient, or something else. That intermediate pretest probability really, really impacted the utility of the VQ scan and how to interpret it. I can't remember the exact numbers, but it was something like 30 to 40% of patients with a positive VQ scan, but an intermediate pretest probability, were left with a sizable proportion, right? 30 to 40% of them actually didn't have a PE at all with further testing. Don't quote me on the statistics, I'm going from memory, but from a conceptual standpoint, it illustrates this idea that how we use testing and how we use pattern recognition go hand in hand, and it's based on probability. So with a Bayesian logic scheme, our action for how we think about VQ scanning and how we interpret VQ scanning, and whether we do empiric therapy for PE in this case, would change based on the combination of pretest probability and the test characteristic itself. Mathematically, It's a combination of sensitivities and specificities, and can be shorthand abbreviated as a likelihood ratio. So if you choose a different test with a different likelihood ratio, you might arrive at a different interpretation and a different likelihood that the patient does or does not have the diagnosis in question. That's somewhat of a technical answer, but does that help a little bit?
Yes, absolutely. I just going off from what you're saying. I was just wondering as well if I know as doctors we sometimes forget the limitations of investigations, and I was just wondering, just going off what you said, is there what is the most sensitive investigation, and for what pathology would you say would we talk about gold standards, but out of the gold standards, from my understanding, there's still limitations to, gold standard investigations. Is that correct?
Absolutely. There's always limitations to every single test that we have. I would argue that there's really only one gold standard, and that's autopsy. And we would prefer not to use that as our diagnostic method. And so, there's a common sort of rule of thumb, and that is most things can present in one of several ways: a common presentation of a common disease, a uncommon presentation of a common disease, a common presentation of an uncommon disease, and an uncommon presentation of an uncommon disease. It's part of what makes clinical decision-making so difficult, because you can't take any single test for granted. And I think this is where approaching decision-making and diagnostic algorithms with a hybrid approach helps us the most. It allows us to switch back and forth between pattern recognition and figuring out, do we need a second test? Do we need a third test before we choose to act? And then always going back to this idea of, well, how quickly do we need to act? A good example of this is, let's say you have a 74-year-old female that presents with dysuria and urinary urgency. There's a human aspect to feeling like we need to act quickly to prevent suffering, prevent the dysuria, prevent the urinary urgency. But we have to balance that with what potential harm might empiric antibiotics present to this patient versus what additional suffering might we endure or force the patient to endure by delaying empiric treatment to getting extra tests. And I think that's very difficult. Bayesian logic can help us to some extent, because it helps us figure out, how likely am I to be wrong? How likely am I to be right? And how likely is the diagnosis that we're considering going to cause huge harm? There is a fallacy in thinking that Bayesian logic is and should be the only way to make decisions, unfortunately. And that's because we can't always get a test to test for everything. Whether that's because you don't have access to it, because your local lab or your local radiologist doesn't have that expertise, or whether it's a cost issue. Certainly in the United States, the cost issue is because of the insurance system and how it's built. In other parts of the world, it's really governed by how national healthcare systems have decided to allocate resources. It doesn't matter where you are, you're always going to have some of those limitations. A good example of this is when we look at risk stratification, for instance, for somebody who has a concern for ischemic cardiac disease. We can go into test properties, like what's the likelihood ratio of a treadmill test with a Bruce protocol, or versus a dobutamine stress echo versus an adenosine thallium nuclear perfusion study. But those discussions become purely academic if you don't have access to a skilled cardiology technician, lab, and a cardiologist to interpret that. Or if you don't have access to dobutamine. So I think your question it's a difficult one that we all suffer from. And that is, if there is no gold standard, and if no test is perfect, and no algorithm is perfect, how do we consistently help everybody that comes into our doors? And the unfortunate answer is we can't. That's the human nature of medicine.
Thank you for that.
Thank you.
Leah, would you like to raise your question? No. You should be able to talk. Just need to unmute yourself. Hello? No? Okay.
There is one other question in the chat from, and I pardon the pronunciation, Ferez talk. It's a very interesting question. I'm glad you raised it. The question is, can AI get better at clinical problem solving than a human? Or should we work in synergy? This is a huge active area of research. And there are definitely limitations to AI. I'll give you a couple examples of that. The first example of that is the limitations of machine learning, for instance. So not to get into too much technical detail, the question was whether you could teach an AI program how to recognize a school bus. And the way they would do that is to show a series of images of different variations of school buses. And at the very end of the day, what they were able to do is to achieve a very high reliability for what a school bus is for the AI. However, they came up with very, very strange answers when given different combinations of yellow and length and size and tires. That technology has been leveraged, for instance, with papanuclear smears or pap smears looking for cervical cancer screening. The technology, when used alone to analyze a pap smear for cervical cancer, proved to be fairly unreliable. However, when compared to a human pathologist reading the pap smear alone, it proved to be equally unreliable. But when you combine the two together, what we're seeing is that it vastly improves the ability to identify and discriminate between cervical cancer and ascus, or atypical squamous cell dysplasia of undetermined significance, from normal cervical histology. So I think that's an example where the synergy of AI and human has shown to be vastly superior to each alone. On the other hand, we see a huge problem when we use AI to just analyze the EMR data, for instance, or electronic medical record data. So early research showed both positive and a negative. They used AI to analyze medical records, so doctors' notes, nurses' notes, lab data, patterns for vital signs, and they were able to show that that an AI was vastly superior in finding early warning signs of danger. So in a famous research, they used AI to comb the electronic medical record and then to track vital signs for a pediatric patient in the NICU. able to predict an impending code situation or cardiac arrest by, don't quote me on it, but as much as 1 to 2 days. Those of you who are fans of Formula One racing, the technology that they were using was borrowed from Formula One race teams and used in conjunction with the Formula One race team. That's an example of some of the success of using AI to augment. The problem was the flip side. When AI was right, they were very, very right. But when AI was wrong, they were very, very wrong. Now, part of that is because human language is very fluid, and using AI to recognize our various idioms, our various vernacular, our various abbreviations became incredibly complex and error flawed. It's something that we're still struggling with in that research piece. And so it's a great question. I think the hope is that some synergy will make us better, but each alone is probably not going to get us there because of the limitations. It's a great question.
Pete, I don't know if you can see the question that Carla posed in the question. You spoke about our own biases. How can we mitigate against that in a clinic? Please give us ways to do this. For example, mixing presentations we see.
I love this question. The answer is probably beyond the scope of this individual webinar. I would put a plug to say, if you all as an audience are very interested in this topic, let us know, and Medmastery can start to create more workshops looking and exploring at that very, very specifically. There are some research proven ways to do this. It's still an emerging science, but it's something that is increasingly being recognized. For those of you who are interested in exploring the topic, maybe not necessarily the solutions, but the topic, I would point you to a research project from Harvard University called the Implicit Bias Project. It's part fun, it's part educational, but it's also very, very enlightening in exposing and learning about our own biases, how it works, how it influences our decision making. I apologize for not answering that directly, but I think we just simply don't have enough time to go into it too much. So again, if you want more, I'm sure Medmastery and I can work out some future workshops.
On implicit, there's entire trainings on implicit bias training that I know institutions do in general to look at that specifically. So yeah, that's certainly an interesting topic that is, you're right, sort of an entire can of worms to sort of open and look at specifically. Yeah. Are there any other questions?
Yes, there is one from Dr. Abbas in the chat. I assume that it's for the Bayesian theory. And the question is that, does this theory differ from what we are using currently when utilizing the information from history or detecting the clinical signs?
The answer is yes and no. So when you're looking at clinical guidelines and algorithms, in theory, we are building those algorithms with some principles of Bayesian logic and Bayesian theory. Certainly, some of those examples are understanding that certain tests are for screening, whereas others are for confirmation, and leveraging that. However, Bayesian theory is a little bit, it differs slightly in that we are using ideas of probability to decide where do we look at first versus second. There was a really interesting article talking about Bayesian theory in one of the United States' popular newspapers, and I can't remember which one. I want to say it was something like New York Times or CNN. And And they took a very trite world, like real life example, and that is, where do you look for your phone if you've misplaced your phone in your house? And there's a lot of different ways you could go about doing that. You could choose to start at one room in your house and then work in a pattern, right? Going left and right and up and down systematically from floor to floor. Or you could use Bayesian logic. Well, is your phone more likely or less likely to be in the bathroom? Or more likely or less likely to be in your kitchen or in the refrigerator? And so the idea of Bayesian logic there is to say, well, it is much more likely for me to have left my phone on the countertop next to the toilet in my washroom than it is to be left inside my refrigerator. So I want to look at the bathroom or the washroom before I would look in the refrigerator. And so that kind of Bayesian logic is not always evident when we think about using algorithms and when we think about using clinical guidelines. That's still, to some extent, the art of a clinician. Does that answer your question a little bit?
Hopefully we'll see them pop in the chat and let us know whether that answered their question. For the sake of time, if anybody has any questions, feel free to pop them in there. I want to just give everybody a quick preview of, we're not going to walk through the whole human DX case that we sent to you in the email, but I just want to give people a preview of what a human DX case looks like, why we even sent it out. This was brought to us by one of our team members, and we thought it was really interesting sort of way of working through cases, sort of a look at collective intelligence and the way that human DX is sharing sort of collective reasoning in terms of putting cases in a platform that clinicians have access to and can sort of test their clinical reasoning. And Pete, I don't know if you have access to sort of change the slide and show them just what the platform looks like. It is app-based. So you have to do it on your phone, which I mentioned in the email when I sent it to you, and I will send it to you again on, like I mentioned, on Friday. So it gives you sort of the history of present illness, the physical exam. It'll also show you any studies that you have, ECG, chest X-ray, that kind of thing. It'll show you who uploaded the case and where they're from. So you can see that this is by Dr. Carle-Illinois and where they're at or where they're located. If you switch to the next slide, Pete, it'll show you, for example, the ECG and the chest X-ray, and you get to sort of work through the case. You can see this isn't the entire case, but you can go to the homepage, solve another case. And we just thought it would be a fun thing to sort of send out the case, give you a chance to sort of practice and in coordination with this webinar, since we were talking about clinical decision-making, clinical reasoning. I'll let Pete comment on that a little bit more, but.
Yeah, so, part of the dilemma of learning is finding enough experience to learn from, enough variation of certain themes so that we can increase our pattern recognition experience, but then also to practice new skills with logic, reasoning, Bayesian theory. What Human DX has done is to allow people to post de-identified cases, essentially crowdsourcing experience. So we may not need to see 1,000 patients with multiple sclerosis to see all of the different variations and understand that. So, you can post your own case with a commentary, or you can read other people's cases with their expert commentary on how they broke down, what aspects of the history, what aspects of the physical exam, what aspects of the EKG or the chest X-ray led them to their decision-making. It's also set up so that you can read a little bit about commentary on how they arrived at their diagnosis. And some of the cases actually give case follow-up. So what happened to the patient after diagnosis or after treatment? For many of you who have read New England Journal of Medicine, they have had this ongoing series for, gosh, multiple decades called Clinical Pathologic Conferences, or CPCs. They are involved, they are very detailed. What Human DX has done is to take that concept and really distill it in short snippets of cases and commentary that you can access while waiting in the elevator for your next floor, or while you're waiting in line for coffee or something like that. So it's a very valuable learning and teaching tool.
Yeah. So we just wanted to share that as a valuable tool that you may want to look into using. So we will share, like I mentioned, that case. If it's something that you may want to check out, feel free to look into their case library, their platform, all of the tools that they have. Like I mentioned, we'll send that out in the email. Pete, if you'll slide to the end, we also have a discount code, also just for anybody that's attended this webinar. For anybody who may be interested in our products, we also have workshop cases. For example, you can see, if you see here, the Inflammatory Markers Essentials workshop, that's Pete's little cartoon character there in that little purple box. And he also has a workshop that goes along with it. So that anybody that's interested in learning more from Pete, he certainly is a great teacher on our website, and you can learn a lot more from him. So we have a discount code here. If you put in webinar 15, you can get a discount off of our subscriptions. So this will also go out in the email that you will get on Friday. I see that there's a couple more questions, so we'll leave this up for the next couple of minutes, and then we'll jump back into the questions and see if Pete can answer some more questions while we have a couple minutes left here. We are working on some neurology cases. I'm trying to think if there's, in terms of neurology workshops, I believe the only ones we currently have are imaging, I believe CT cases. We're currently working on a neurology workshop. There is
one neurology primary care case series, I believe, on headaches and migraines.
Yes.
If I recall correctly. And then I'm trying to remember what else is on there.
Let me go to our case library.
And I'm sure Medmastery is always looking at what other workshops are missing so that we can start to create more. So
yes, also if you have suggestions and you see, hey, I see that you have a course in this, but I'd love to see more workshop cases, feel free to reach out and let us know. Because sometimes people, they go through the course and they say, hey, I learned a lot from your depression and anxiety course, but I would like to see workshop cases on this, or I learned a lot from your headache masterclass, but I'd like to see workshops. Feel free to let us know, if you want more cases in certain areas. We can certainly look into developing more things there. We have a brain CT workshop, for example. There's some other questions up here. How do we get in touch? Support@medmastery.com. You should be able to reach us.
And that should be COM, not COMO, I believe.
Yes. There's some more, let's see. Are there any studies that illustrate the extent to which concerns about medical legal consequences influence diagnostic decision-making internationally?
That's an interesting question. I don't know of any off the top of my head. I think part of that is limited probably by how different the legal systems are from country to country, and what is or is not liable. So I don't know for sure. In the US, most of the liability favors physicians in their decision making. The general rule of thumb in the US is you're not penalized and you're not found guilty of malpractice if you're wrong. You're held liable if your decision making is so unusual and so faulty that you neglected usual things, usual considerations. But that is a good question. I'm curious how that changes from country to country.
Yeah. Is there anything else? We have about a minute or two. I want to be respectful of everybody's time and make sure that we log off because I know other people may have clinical places to get back to or other responsibilities. I want to thank Pete for his time for joining us. We appreciate it. I know there was a lot of really thoughtful questions, and I really appreciate his presentation and the time that he dedicated to showing all of his expertise and knowledge with everyone here, and for everybody's really thoughtful questions as well.
Thank you all for joining us from everywhere in the world. I think these are important questions, important topics. I'm glad to start the conversation with you all.
Thank you, everyone. If you have any other questions, like I mentioned, we'll be sending out the recording on Friday. We'll also be sending out the discount code and the case so that you can check out more Human DX cases. If you have any other questions, feel free to just shoot us back an email when we send out that email, and we'll be in touch there. Everybody's saying thank you, thank you. Thanks, everyone. I really appreciate it. I appreciate your participation, for joining us. I hope everyone has a wonderful rest of your day, evening, morning, wherever you are in the world. Thanks for joining in with us.